how to solve this issue. I said, okay, well, if you don't mind leaving the implant, the original implant, we can modify it. We can change it with the soft tissue only. That's fine. So she was when I check the X-ray, it's 30 degrees of the angle of abutment. It's ankylosing implant. See how much of axial placement by the previous dentist. So I remove it, and then I make a temp. With the temp, I can adjust the profile, and that's the time I harvest connect tissue from the palate. This is Bruno technique. And then what I did, I create a pouch with a microblade. Microblade, create a pouch, insert the connect tissue on the buccal side. So my goal is to create more tissue on the buccal and quickly advance the blood and the tissue. So I can cover the tissue and thicken the tissue and gain the aesthetics. That's my goal. So if you look at X-ray, look at the video, see I have microblade and the connect tissue just slide it in. And after I slide in the connect tissue, I put the provisional back and suture it up. Because we cannot have that the patient walk out of the office without a tooth, the central. Alright, essentially, it can be done at the same time. So this is the final result. Yes, as my promise her, I create the environment that she would never notice and solve the problem with a very simple, easy way. Alright, this is before and after. Alright, so, and not only I change the soft tissue, I modify the crown. I make it better. So bone, there was bone on the buccal, but the problem is the implant is off axial placed. So it's a compromised implant position. So I need to control the emergence profile, and I need to increase the soft tissue thickness, and to create the environment mimic the adjacent teeth. Okay, teeth. All right, let's get to the more difficult one. Patient have a big problem here, missing the lateral, and create a lot of touching loss on the adjacent, the central and canine, which is problematic, and that will affect the aesthetics. She was told to have the central canine extracted, but then I say no. We can create something that you solve your aesthetic issue, and if you are satisfied with it, then that's fine. If not, we can always extract the adjacent teeth, right? So what I did, I kind of try to grow bone back. But apparently she had the attachment loss and bone loss. That's a very good, we didn't have the growth factor in Taiwan, but we have endogain. I try to use endogain to help out for the biology, but it's not a good choice. Why? Because endogain is flowable. It's not consistent for bone augmentation. I tried this, but then it worked out a little bit, but not as my expectation. So in the end, I had to place the implant and did my bone augmentation again in order to gain more peroneal regeneration and bone augmentation on the buccal. So now implant placed. What should I do? Yes, we did gain some soft tissue, we did gain some bone, but it's not that aesthetically, I would say, satisfaction. So I took a piece of connect tissue in this shape. I put it to cover the adjacent teeth and also the edentulous side, and then suture it up. Guess what? I thicken enough tissue and compensate certain bone loss. And at the end, I solve the issue for the patient. It's not perfect, but then she was happy about it. It's before and after. Can it be sustainable? Yes. In 3 years for the follow-up, everything in position, nicely, even though she had a more recession for the bottom teeth, all right? And she had another problem of the previous implant here, but we were dealing with that. So there was a limited bone on the buccal side, so we need to increase the bone. We have maximized the vertical bone level. Implant position, proper implant position is very important. And if we don't have enough bone, then we need a soft tissue to get extra on it. So soft tissue can compensate the bone, right? As I mentioned, bone, soft tissue, implant position, they all affect each other. So that's the key. Now let's get to the hard tissue reconstruction. For the hard tissue, we have we have stage approach, both, right? So if you look at this missing teeth, patient have the teeth extracted and came to my office. So when I look at the x-ray, yes, there's a lot of bone loss, but what should I do? That's fine. We can place implant, whatever it can be placed. And for those areas, but very thin area, we grow bone first and place implant later on. So why I did put immediate and stage at the same time. I use non-resolved membrane to build up the bone and close it up. And this 7 months, if you look at here, we have implant position and good bone. And now we get more bone for this ejector side, right? It was very thin before. Now we have enough good bone. So I place implant, and it will be simple because I have enough bone. But remember, we didn't have that much bone. So for this particular patient, I need connective tissue, but she just didn't want it. She didn't want another surgery for the connective tissue. Sometimes it happens. So that's the best I can do with the bone only, without soft tissue grafting. It could be done better, so much better with connective tissue graft, thicken the soft tissue. Okay? For this particular patient. But look at the bone I create, it's good enough. And before and after, it's sustainable, yes. 4 years post-op, still the same, everything in position. And that's building on the bone. No matter it's staged simultaneous, whenever you can build up the bone, it's fine. Whatever technique, the most important thing is to build up the bone. We need to have a good implant position. And post-bone obtaining soft tissue is very important. We gain soft tissue, we gain volume, we gain connective tissue, but if patient doesn't want it to be done, then sometimes we have to compromise. Okay? So, ideal way for those severe cases, we need both hard tissue and soft tissue. Let's talk about immediate implant. So this very young lady, early 20s, she came to my office after the ortho. She had this kind of restoration. She was not happy about it. So look at it. Yeah, it's not enough bone. Guess what? I checked it, placed implant at the same time. I grabbed it at the same time. Bone, membrane, soft tissue, everything at the same time. I just want to make sure I have enough bone, soft tissue, and everything should close up as the primary closure. That's the key. 6 months after that, this is before, after. In 9 months, we could have that restored. And let's look at 8 years, follow up. Still symmetrical. The only thing different is that I placed one more implant here for her because she had the lateral incisor that was endo-treated and fractured. And this is 13 years. We think 13 years, everything stayed stable with good bone, implant, and soft tissue. Remember, those play vital role for implant aesthetics. Okay? If you can appreciate the bone, everything nicer. So, if there was no bone on the buccal, we need to build up the bone and soft tissue. Compromise implant position, because the bone is not ideal, then we need more bone and more soft tissue. Remember that. It affects each other. Soft tissue, we need a very dense and thicker tissue for this purpose. Alright, so let's get to the second case. A patient has a fractured front teeth. A few of them are fractured. This is the problem. So what I did, I removed those hopeless and asked the endodontics to treat those possible we can save them and live in this aesthetic challenging situation we have. So I have the implant, 2 teeth extracted, and then I need a surgical guide. And I place implant, bone graft, membrane, connect tissue, all at the same time. Remember, when people say when you do immediate implant, don't refract the flap. Otherwise, it would jeopardize the soft tissue. No, we have to do it if we have to. Because if there was a defect, you need to refer the flap to deal with that defect. You know, open the flap is not an aesthetic compromise situation. But to do it wrong is a problem. So we have to do the things right, okay? So this is, I get a tissue from the palate and took out the epithelium and grabbed it at the same time. So this is the result, all done at the same time, immediately. And the second stage and the final restoration. For this this lady, even though aesthetic may not be quite, she would just want a functional representation, but then given a very good aesthetic result, she was so happy about it, you know. And then it's before and after. Look at the difference. Oh, this is the same person. It is the same person. Just, you know, after done with the final restoration, she had the makeup and everything, and looks like a different person. But this is the same person, okay? Alright, dehiscence bone. We need to build up the bone. We need to place implant in optimal position. We need soft tissue. So all of them would go together to hold up the implant aesthetics. That's very important, okay? Alright, now we're going to the compromised bone situation. The compromised bone situation. Very bad. We need to build up the bone, place the implant in the right position to maintain proper soft tissue volume and keratine tissue and get aesthetics. So those are very massive destruction. I will talk about vertical bone loss case. So this lady, 36 years old, she had an implant placed 10 years ago, more than 10 years ago. And everything just being not right and gut fail, you know, is failing, and pus, abscess, everything just not right. So she came to my office. The first thing I did, I took them off. I removed all the implant because they are not savable. All right. First of all, the tremendous bone loss. Second of all, there are perimentitis, and there's no way I could keep them. But look at here. There's a tremendous defect I have to deal with. So what I did, I used a tennis screw, bone graft, and non-regional membrane. I did vertical ridge augmentation and create enough bone. Even though I create a lot, but still not enough. Then we have soft tissue. But then think about the vertical augmentation I did. We have enough bone to accompany, to place our implants. And now what should I do? Soft tissue. So we harvest connective tissue with the epithelial technique. I published this technique with Dr. Kim and Dr. Nevins, 2018. IGPREs. And this is connective tissue. This is free graft, and the epithelial is with laser. And I grabbed it just like connective tissue graft. And when I have enough thickness, I did another split thickness. What I did, I harvested another piece of connective tissue as free graft. The epithelial as free graft. So this is the final result. So from here to here. So for this lady, even though it's not like a little bit long, but it's not that long. You know, people weren't aware of it. And she was happy about this result than before. So this is the final result. If you look at the before and after, it's a big change. And I'll show you another case. Patient had the vertical ridge augmentation done twice in the office, and her dentist did it twice, but all failed. she came to my office with this. I said, there's no way I can close it up. We need to have that removed. So I referred this patient back to her dentist, to have that membrane removed. She had that membrane removed 2 weeks after that. And not enough time. We have tissue moved back. And 2 months after that, yes, we have more tissue coming up, but not enough. And one thing you got to notice that the canine didn't have enough canine tissue and also very thin tissue. That would jeopardize our bone augmentation procedure. So what I did a connective tissue graft to thicken the tissue on the canine to get it ready for the bone augmentation. Just it. If you look at here, a huge defect, right? Big no. Don't worry. We just need to go to the back. And this is not the deepest part. The deepest part is approaching 15 millimeters, right on the corner. And then I removed the incisive canal because it's in the way. And I grabbed it, tendon screw, free dry bone, and very thin layer of biomass and non-resolved membrane, all packed at the same time. And primary closure is the key, always the key for vertical regional patients. So this is the result. I wait for 18 months. In general, for bone loss more than 15 millimeters or more than 10, we need to wait about 12 to 14 months without autogenous. Those cases, I did zero, no autogenous, okay? All free dry bone and zero graft, no autogenous, okay? And think about the bone graft and surgery we can achieve. We don't need autogenous, even though a lot of people say we do need autogenous. No, if we can do it right, we don't need it. I haven't used autogenous ever since 2007, okay? All right, so this is the soft tissue level. I did a partial picnic. So this lady, she didn't want connective tissue graft because I told her I need 2 grafts, 1 connective tissue, 1 free graft, but she didn't want. She can only take 1. So I told her, if we just have 1, we'll do free graft because connective tissue is more important. Okay, connective tissue is important for health, but volume-wise, that was good for aesthetics. So she liked to have just 1 graft done. So this result is not ideal because we didn't have the chance to do the connective tissue graft, but just free graft seeing the result, that could change for her. From pink person to just implant restoration. Last case, we have about 5 minutes. I'll go really fast on this final case. Patient have multiple natural teeth failing for the athleticism, and she will suffer this problem and couldn't chew on it, and very compromised posterior dentition as well. So I extract all of them from the central canine and replace with a membrane bridge. It's a acrylic membrane bridge. So 2 months post-op, this would be ready for me to build up the bone. So this is the bone. Apparently needs to be built up. So I opened it up. What I did, I did it differently. Incision-wise, buccal pressure incision, tendon screw. I used two types of membrane, non-resolvable and resolvable. Work together. Those membranes work together. Non-resolvable, resolvable, keep up the space, keep up the height. Resolvable, help out for the blood supply. So they will do their job better. Alright? So I have 4 screens, you can see whatever you like. If you don't get a chance to see it at all, next time you can see it. Every time just follow 1 screen, okay? As we don't have much time, so I just jump it. This is the non-resolved membrane, resolved membrane. And I suture it up. Guess what? We have enough bone. So this is when in 10 months, we open it up, see the bone, vital bone, very healthy vital bone. And I advise patients to have 4 implants. We can do 2 bridges. And she didn't want it. She wanted individual because she said, I have breached all these years and don't fail. And then I was so upset about it. So I don't want any breach at all. But I told her, with the individual implants, we have very, papilla. The papilla will be very short. But she said, that's okay. So I just followed what she expected. I placed 6 implants. And I grabbed it again to protect the bone. And what did it differently? I make a partial thickness, flat. I harvest connective tissue from a palate with the deepithelializing technique. And I suture it up, suture the graft. And just wait. Wait for maturation, 2 months. And I use the laser, the water laser, to deepithelialize the mucosa and expose the canalized tissue and uncover the implant at the same time. So those are provisional crowns. So I'm giving the provisional crown because she had the final crown, but we haven't really finished this case yet because the traveling issue. But I'm pretty sure that we can finalize it really soon. So no bone, no aesthetics. Pump implant position is a must. Soft tissue, we need volume, we need canal tissue. Okay? Those are very important. So at the end of my presentation, I would like to share with you a take-home message. The aesthetic dentistry is something that requires the multidisciplinary approach, right? So we do need perio, we do need, sometimes we need ortho. Perio, ortho, plus implant, right? So build up or modify the foundation of the dome and also the gingiva soft tissue. They are essential for achieve through the foundation. We need soft tissue. We need implant position right. Bone implant position, soft tissue, prosthetic, aesthetics. They construct the whole aesthetics. Bone is the top priority. We got to remember foundation, okay? Bone can override the need for soft tissue. Remember that. Soft tissue can compensate the bone issue. Soft tissue makeup sets the tone and make up the deficiencies. Okay? You just need to remember, soft tissue is not everything. The soft tissue can set the tone. Soft tissue can make up the deficiencies. It's not true deficiency. It's not true bone, but you don't see it. Okay? Bones. This is the final equation I want to give to you. Bone, soft tissue, implant position, emergent profile equal to aesthetics. So I would like to thank you for your attention. This 1.5 hours. There's a lot of material, a lot of contents I want to give, but in this tempo, I hope you enjoy it. And then you're very more than welcome to reach out to me by email or social media. I'll put some video